Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and I am so happy to have Dr. Christopher Gist here with us today. He is with Southwest Premier Urology. He is actually working with Dr. Tristan Berry. If some of you might know him, I know we've had several talks with him before. He has just started over here. He's actually moved from New Mexico and is now practicing in Tucson. He specializes in treating intimate women's health conditions, including bladder leakage and pelvic floor disorders, which can negatively impact the quality of your life. So I welcome Dr. Gist. Oh, you're muted.
Thank you. So today's topic is understanding urinary incontinence. I'll try to make it as interesting as I can and hopefully at least informative. So today we'll discuss common treatment options, the most common types of urinary leakage that we tend to see in the office, and potential causes of the incontinence. So it's quick definition of urinary incontinence. Simple definition is it's just the loss of urine when you don't want to lose it. And it's estimated that approximately 1 in 2 adult women in the United States will have some form of urinary incontinence. So you should not feel like you're alone or you're by yourself, because a lot of women do have this issue and suffer from this problem. So the most common types of urinary incontinence we tend to see in the office are urge incontinence, stress incontinence, and then mixed incontinence. Urge incontinence is oftentimes women will complain of feeling intermittent pressure or bladder spasms, and they don't have enough time to get to the bathroom, and they have the leakage. And essentially the bladder is contracting uncontrollably, causing that sensation and that loss of urine. The stress incontinence, usually when women exert some sort of abdominal pressure or stress from lifting, coughing, laughing, sneezing, then they'll get a loss of urine. And of course, mixed incontinence is a combination of both. So in my practice, I tend to see about 50% of women that have stress urinary incontinence. I would say about 30% with the urge incontinence, and then the remainder, they'll have a combination of both the stress and the urge. So again, urge urinary incontinence, quick definition, overactive bladder symptoms, uncontrolled bladder contraction. Women will often say that they'll go to the bathroom more than 8 times in a day. When they go, they just have small amounts that they tend to void. Again, it'll be a strong, sudden urge, and oftentimes they won't have enough time to make it to the bathroom before they lose that urine. The stress incontinence, again, it's any type of abdominal exertion that's put upon the bladder and the urethra that causes the loss of urine, jogging, coughing, sneezing, lifting, what have you. Those are the common causes. So when we evaluate women in the office for stress urinary incontinence, we're looking to see if they have one of 2 types: hypermobility or intrinsic sphincter deficiency. So hypermobility is just a laxity of the pelvic floor, muscles and ligaments that causes movement of the bladder and the urethra when that abdominal pressure is being exerted, when they cough or they run or they laugh or they lift. The other one is an intrinsic sphincter deficiency, which just a simple definition, it's damage to the sphincter muscle. That damage could be from trauma, it could be from radiation, and certain medical conditions or illnesses can affect the nerves to the urinary sphincter that causes the sphincter to not completely close. So it remains open, and then of course the urine leaks out from the urethra. So that's hypermobility, and that's intrinsic sphincter deficiency, damage to the urethral muscle. So potential risk factors for stress urinary incontinence: age, women that are postmenopausal, no longer producing estrogen, pregnancy, women that have had multiple vaginal deliveries, hysterectomies can contribute to the stress urinary incontinence. There is some overlap between causes for stress urinary incontinence and urge incontinence. Smoking, diet, medical conditions like diabetes, MS, cerebral palsy, things like that can also cause urge incontinence, and sometimes overlaps with the stress urinary incontinence. And again, women that have the mixed incontinence, they can have, potential for both risk factors that cause the mixed incontinence, which is stress and urge. So treatment options. A lot of women won't seek treatment for it. Either it's not bothersome enough to them to where they feel like their quality of life is being impacted. It might get to that point at some time. Women might not feel comfortable enough to discuss it with their physician, and they might not realize that there are treatments out there available to them that we will try to help improve their quality of life. But hopefully you have a physician who you feel comfortable enough you can have this type of discussion with, and they can get you the necessary referral so that it can be addressed. So urge incontinence or overactive bladder treatment options. For both types of incontinence, I would say most urologists will try conservative things first. We don't always jump to medications or surgeries. We try to maybe have you change a little bit of your lifestyle with your diet, or have you do pelvic floor exercises, which might help with the incontinence. A lot of times we'll send patients to physical therapy or occupational therapists so that they can get some sort of pelvic floor training or biofeedback to help control the urinary incontinence. For urge incontinence, if the more conservative treatments don't help or change things, then we first go to oral medications. And I can tell you that there are at least 10, like 15 to 20 different oral medications that are out there that treat the urge incontinence or overactive bladder symptoms. I can tell you that the bladder itself has at least 7 different receptors, and a lot of those medications treat different receptors on the bladder to try to control those urge symptoms. When the medications fail, a lot of times we'll move to Botox, which is an office procedure. The Botox is done with the office cystoscopy, where we inject the Botox directly underneath the bladder lining. That it's often helpful, especially in patients that suffer from neurologic disorders like MS and Parkinson's, cerebral palsy, things like that. If the Botox injections don't work, then we'll move to neurostimulators. These are devices that we implant near the tibial nerve, sometimes the sacral nerve, which try to help regulate the uncontrolled firing of those nerves that stimulate those bladder contractions with the urge incontinence. Treatments for stress incontinence. Again, we go the conservative route first. Kegel exercises, which a lot of women are very familiar with, contracting those pelvic floor muscles, that sphincter muscle off and on, especially when the abdominal pressure is being exerted with coughing, sneezing, or laughing. You squeeze and hold, try to hold the urine back. Again, we send patients for the biofeedback to try to help train those pelvic floor muscles. Some women will see GYNs and have pessary placed, especially if there is prolapse or there's laxity in that pelvic floor, to try to prevent the pressure from the uterus or the bladder. We do bulking agents. Bulking agents are mainly used for intrinsic sphincter deficiency. Again, that's the damage to the sphincter muscle. The sphincter doesn't completely coapt or close, and then the urine leaks out. So and this is a endoscopic office procedure that, again, it's usually done in the operating room, but it's an outpatient procedure that usually takes about 15 minutes. We inject the bulking agent in and around the urethra and the sphincter area to try to cause that coaptation or closure to hold the urine back. Then we'll move to slings, which I do a fair amount of, have been doing it, slings for over 20 years. The slings are placed underneath the urethra, and it's placed underneath the urethra to try to give it support so that when the abdominal pressure is being exerted, there's still closure and coaptation of the urethra, so that when you cough, laugh, or sneeze, you're not having the leaking. And I would say that, as a surgeon who places sphincters, if a patient ends up getting that procedure, I would expect somewhere between 90 to 95% success rate for my patients. So it tends to be very successful. Some more invasive surgical treatment options with the bladder neck suspensions, the MMKs, and the Birch procedures. Urologists don't typically do those procedures. In our literature, those procedures are not successful. So usually it would be a gynecologist that would perform those procedures. And again, most of those more invasive procedures have fallen out of favor. And a lot of that also is due to the fact that the mid-urethral slings are so successful. So this is just a picture of the bulking agents that are placed in and around the urethra to cause that closure of the urethral lumen. I will say that a lot of times there is some absorption of the bulking agent, and patients will be required, or not required, but will have to have this procedure repeated at some point. I can tell you that when this procedure fails, then the go-to would be the mid-urethral sling. So again, mid-urethral slings have been around for a while. It is mesh, which is a foreign body that's placed underneath the urethra. It has stood the test of time. There is a lot of literature out there about mesh in the pelvic floor area. This mesh, again, is FDA approved. It has proven to be safe over the years. It's not the mesh that you have heard about that has been removed from the market or use to repair pelvic floor prolapse. Women have had cystoceles or rectoceles. I used to use that mesh as well, even though I think all of those types of meshes have been recalled and removed. I personally did not have any problems with it. I used to teach that course, Boston Scientific. They probably don't even know that, but 10 years ago, I would go teach the course in Chicago, teach OBGYNs, urologists how to place the mesh. So I personally didn't have any problems with it, but there were a lot of complications associated with it. And most of those types of meshes have been removed, but it's not the same as the mesh that we use for the mid-urethral slings. And again, when I place a sling in a patient, I expect a very high success rate. For patients that still have some leakage after placement of the sling, they still will usually say their quality of life has been greatly improved. And very rarely would I have to go back and make a revision. And if I had to make a revision, usually it's just making the sling a little bit tighter, which again, you have to be careful with. We calibrate when we place this mesh, how tight it should be around the urethra. So, tightening the sling around the urethra could potentially lead to some of the complications that are associated with using that synthetic material, which is erosion into the urethral lumen, which again, it still probably occurs, but I would say less than 1% of the time you would see a complication like that with placing a sling, and especially in the hands of an experienced surgeon. So again, we still give our patients literature on the mesh being a foreign body and the potential complications that can arise from it, but it is few and far between that we expect complications from. So this is just a picture showing where the mesh or sling is placed underneath the urethra. It's just like a hammock. Literally, we would make a 1 centimeter incision in the vaginal mucosa right underneath the urethra, and we would place it there after calibrating how tight it should be around the urethra. And again, it's outpatient procedure, takes 25 minutes, and it's very successful. So for the women that have both stress and urge incontinence, we do from time to time have to treat patients with surgery, the sling or the injectable, and oral medication. And again, that's after trying the more conservative treatments. But again, there are a subset of women who will need both types of treatment. So what can you do? First, you have to talk to your physician about the problem. Let them know that it is affecting your quality of life, and you would like to maybe speak with an expert to see if something could be done to improve your symptoms and your quality of life. I would say that's the first step in doing it. Again, you shouldn't feel like you're alone. Huge part of any urology and probably gynecology practice where incontinence is an issue. So the first step is talking to the physician and then seeking the expert advice and opinion and workup from the person treating it. So yeah, there are tons of testimonials out there from patients who have had treatment for all types, and can attest to the effectiveness and improvement in their quality of life. So that's pretty much it. Thank you. If you guys have any questions, I'm more than happy to answer.
Thank you so much, Dr. Chris. I do have a couple of questions that have come in. One was regarding Botox. Is that a treatment that needs to be repeated?
Yes, that treatment does need to be. Oftentimes, we'll do that. We'll have to inject Botox after about a 6 month period of time because it does tend to wane after a period of time. So if women see a benefit, then yes, we'll repeat it 6, 9 months later.
Okay.
Yep.
And if somebody is needing a procedure, the Sling procedure,
Mhm.
what is the recovery like for that? And how long does it last? How effective is it, and how long does something like the Sling last?
Okay, so when I place a sling in a patient, I expect it to last a lifetime. One of the things I'll ask the patient, especially a younger woman, is if she's done having kids. If she's not sure that she's done having children, then I wouldn't recommend her having the sling until after she's done with childbirth, because that can affect the sling. So as long as she's done with childbirth, then I expect when I place it, I expect it to last a lifetime. Um, in terms of recovery, so women go home the same day. Um, they'll have I usually will leave vaginal packing in for 2 to 3 days that they'll take out on their own at home. Um, they usually go home without a catheter. Um, so the only time they would go home with the catheter is if they weren't able to empty their bladder in the recovery prior to being discharged, because we want to make sure there's no urinary retention. Sometimes you can get that from swelling from the surgery, but they go home without a catheter. I tell women they can go back to work within a week because it's not a very painful operation. Like maybe I'll give them 3 to 5 tablets of pain medication, but it's not very painful. I would say the most uncomfortable thing is the vaginal packing. I tell them that I don't want them to lift anything heavier than a gallon of milk for at least 6 weeks. And by 3 months, I would expect them to go back full time in the gym and lift whatever they want and go back to their regular routine.
What's the average age that you tend to do this procedure on? Is there an average age that you're seeing?
So the age range can be 35 to 85 and older. But on average, I would say most women in their 50s to 60s, the age range. Yeah.
Great.
Yeah.
Now, I had another question come in asking, can anyone do a teleconference and maybe describe the symptoms that they're having right now during COVID, or do they need an actual appointment?
Yes. Teleconference is fine, especially for the first visit, because the only thing we wouldn't be able to figure out with that televisit is with the physical exam to see if there's any mobility or intrinsic sphincter deficiency. But yeah, we can diagnose just based on what the patient's symptoms are over the phone. And then if additional workup is needed in the office to figure out what else we're dealing with to see, what they're a candidate for, then that can be done in the office. But yeah, the first visit can certainly be telemed.
Oh, great. Okay. And I've put the phone number up there too as well, Dr. Gist. It's 324-4649. Sorry, 4659 for anyone who might like an appointment. I have a couple other questions that have come in. One was about the difference between maybe a bladder infection and a kidney infection. How do you know the difference?
Okay, so bladder infections can produce, again, those overactive bladder symptoms and lead to incontinence. So the difference between a bladder and kidney infection is, so the bladder is considered lower urinary tract. The kidney is considered upper urinary tract. So with kidney infections, most of the time you're going to get flank pain, fever, and chills. Okay. And I would say a kidney infection tends to be more serious than a bladder infection. Okay. So sometimes these kidney infections actually, a lot of times patients will end up in the hospital. But the lower urinary tract infection with the bladder, again, you can still get fever, chills, blood in the urine with both, but they tend to be a little bit milder. It doesn't often lead to hospitalization.
Okay. Okay, so I've got another couple of questions that have come in. One is, do repeated bladder infections cause incontinence later?
So, it depends on how severe the infections tend to be. No, typically they will not cause incontinence later. However, at the time you're having the infection and you're having those symptoms, you could be experiencing the incontinence. But if the infection is untreated, and let's say it starts to damage the bladder or the urethra, again, that can lead to like intrinsic sphincter deficiency. If you're someone that has to constantly be instrumented or have catheters put in, or with the infections, then again, if that causes damage to the urethra, then that can cause incontinence later. But I would say for the most part, no. Urinary tract infections, they cause the incontinence symptoms, but it's not going to lead to incontinence when you don't have the infection.
Okay. And I've got one last question two more questions. What is the treatment for an atonic bladder? Well, I've got somebody who is 81 years old and they're asking about an atonic bladder.
So, an atonic bladder is a bladder that it doesn't contract. It's not functional anymore. And so when we see men with atonic bladders, usually that's from prolonged outlet obstruction from the prostate. But in women, for various reasons, whether it's medical diseases or spinal cord injuries or what have you, if their bladder is not contracting anymore, there is no medication on the market that is going to cause the bladder muscle to contract. There is no surgery. Those interstem sacral stimulators that are put in is not going to cause that bladder to work again. So usually you're talking about some form of catheterization. So you're talking about either intermittent catheterization. Some people have suprapubic catheters. So that's typically what you're going to look at with a bladder that does not work.
Okay. All right. And then the last question that I have here is about over-the-counter medications. What do you recommend for frequent urination?
So when we evaluate a patient for frequency, men and women, right? I mean, we look at their medication list because there's some medications that patients are on, like those water pills, those fluid pills, so they can eliminate water from their body that's going to cause it. Sometimes that requires an adjustment in their medications. We always ask about constipation. Constipation, the colon runs right underneath the bladder, and so if a patient is constipated, that colon is going to be pushing on the bladder constantly. So we want to make sure that constipation is an issue. So either they increase the fiber in their diet, or they take laxatives to help relieve the constipation. But when we're prescribing medications, like I don't think there's any one medication that's out there, and again, there are a number of them, that's any better than the other one. Again, these medications that are out there, like a lot of them work on different receptors in the bladder, and there are a lot of different receptors. So, we as doctors that are trying to help improve the quality of life and the symptoms will often have to use different combinations of medications to try to control overactive bladder symptoms. And so sometimes it takes more than one different medication working on a different receptor in the bladder to control the symptoms. So, I don't have a favorite. I don't work or get paid from any of the pharmaceutical companies. I don't think there is one. I can tell you that there are some of the newer medications that are out there, and I'm not going to mention it by name, but they don't have side effects that some of the other some of the older medications have, and so we might try those, especially if someone's suffering from constipation, because a lot of those oral medications, almost all of the overactive bladder medications except for one, will cause dry mouth and constipation. So if constipation is an issue, then that'll make me use, the newer medication. And newer is not always better, and usually newer is more expensive. So it really just depends. But I mean, like these are questions that are great, and these are questions that we would be figuring out together during the telemedicine visit, or the in-person visit, because all of this stuff plays in or factors into, how we treat patients.
Great. Okay. Well, thank you. That's all the questions that have come in today. I want to take this opportunity to thank you for being here and for sharing all about bladder issues. I know we always get a lot of questions about this, and so I'm so grateful that you were able to sort of clear some of those up. If anyone does want to make an appointment, I did share the phone number for an appointment for Southwest Premier Urology, but I'll put it up one more time here. It is 520-324-4659. Thank you so much for being here today, Dr. Guest. We appreciate it.
Yes, thank you.